Hello and welcome to part 3 of clinical cases for the endocrine block. Today we're going to be taking a look at some more of the syndromes that are associated with the endocrine system, and these include Conn's congenital adrenal hyperplasia, abnormalities of the thyroid gland including hypo and hyperthyroidism, as well as Graves and Goiter. We're also going to look at Pheochromocytomas and what they are, as well as Paragangliomas. So to start with, let's have a look at Conn's, or primary hyperaldosteronism. So Conn's is the equivalent of primary hyperaldosteronism, and it's as a result of excess production of aldosterone by the adrenal glands. Now this is independent of the renin-angiotensin system, so it does not involve the RAS system at all. It is simply an abnormality associated with the adrenal gland which causes this excess aldosterone. As a result, we see suppression of the renin-angiotensin system because we've got high levels of aldosterone in the system, and we see decreased plasma renin. So renin, of course, is what kind of the starting point, if you wish. Kidneys release renin to combine with angiotensinogen. This is the start of the renin-angiotensin system. Because primary hyperaldosteronism is not related to the RAS system, we see decreased plasma renin. And this is one of the key differences we see between primary and secondary hyperaldosteronism. So secondary hyperaldosteronism is as a result of increased renin stimulating the renin-angiotensin system, and as a result we get increased aldosterone. So therefore, secondary hyperaldosteronism, we would see increased plasma renin levels. So overall, hyperaldosteronism normally develops in patients with poor renal perfusion, arterial hypovolemia, and pregnancy. So in terms of diagnosis, we can look at our plasma levels, so are they hypokalemic? We can also look at their aldosterone to renin ratio, and this will allow you a more conclusive diagnosis of whether it's primary or secondary forms. We can look at CTs and MRIs, so for example we can look at the adrenal glands, and we can look at the pituitary as well, for example, to see if there's a problem higher up, and then we can have a look at functional imaging as well. So in terms of the symptoms for hyperaldosteronism, the symptoms are very similar for primary and secondary, and they are very focused around hypertension, hypokalemia, so low potassium, fatigue, headache, and muscle weakness and numbness. In terms of treatment, this can be medical or surgical, and we do have to understand what kind of conditions going on. So is it unilateral, bilateral? So if it's unilateral, surgical treatment is normally the best option because of course we leave one adrenal gland in, which is sufficient, it kind of compensates. Whereas if it's bilateral hyperaldosteronism, of course we can't remove both adrenal glands, and therefore it's medical treatment. So for example, mineralocorticoid antagonists, so for example things that would block the production of mineralocorticoids, which are aldosterone essentially. So the prognosis for this is pretty good as long as we diagnose it early and treat it early, and the outlook for secondary hyperaldosteronism really does depend on the cause, the underlying pathophysiology behind it. Next we have congenital adrenal hyperplasia, and what's really important to remember about this condition, it's as a result of a defect in the enzyme 21-hydroxylase. Now what's really important about this is that more than 90% of cases of congenital adrenal hyperplasia are linked to a deficiency of this enzyme 21-hydroxylase. So it's an autosomal recessive condition as a result of a mutation of a gene for enzymes which produce the mineralocorticoids, glucocorticoids, and sex steroids. And essentially remember, all these pathway steroids come from cholesterol. It's a long pathway, but the key important fact is it's derived from cholesterol at the start. So we can have classic congenital adrenal hyperplasia and non-classic. So classic is where we have a severe or early onset form, and this can be either salt-losing or simple virilizing congenital adrenal hyperplasia. And these patients will have a complete insufficiency of cortisol, they will not have enough of it. On the other hand, we can have non-classic congenital adrenal hyperplasia, and this is much of a milder form, and we still get some cortisol production. We get an accumulation essentially of precursor molecules, but we don't actually get enough of the cortisol production, and it causes virilization, oligo or amenorrhea in puberty, but there's no disorders of sexual differentiation in this case. In terms of treatment, we can use glucocorticoids, and depending on what type of congenital adrenal hyperplasia it is, we may want to use mineralocorticoids as well, or sodium chloride supplements as well. Now to look at the thyroid. So first of all, if we look at hypothyroidism, so this is where we're not producing enough of the thyroid hormones. So the thyroid hormones are T3, triiodothyronine, and then we have T4, thyroxine. So hypothyroidism is where we're not producing enough of these, and it could be a primary problem, i.e. it's a problem with the thyroid gland itself, or it could be a secondary problem, and this is a problem that's from higher up. So like we discussed in the last video, a secondary problem comes from a pituitary or the hypothalamus. It's got around a 1 to 2% prevalence in the UK, and what's really important is it's 10 times more common in women than it is in men, predominantly those older women. And it can occur as a congenital form as well. 1 in 4,000 newborns can suffer from hypothyroidism. It's really important to differentiate the symptoms between hypo and hyperthyroidism, and they're usually the opposite, as we'll see in a moment. So the classic features of hypothyroidism are fatigue, weight gain, dry skin and hair loss, an intolerance to the cold, coarse facial features. There may be a goiter as well, bradycardia and edema, and we'll have decreased reflexes, so hyporeflexia, alongside hypothyroidism. So that kind of makes sense if you think about it. Now, if it's primary, what we'll see when we do our investigations, we'll see an increased TSH, but a decreased T4. So in other words, we're producing plenty of the TSH from the pituitary gland to stimulate the thyroid, but the thyroid's not responding appropriately, and therefore we have a decreased level of thyroid hormone. If it's a secondary problem, it's a problem from higher up, i.e. if we produce the right level of TSH, we would be able to still produce the thyroid hormones. However, we're not producing enough TSH from the pituitary and the hypothalamus, and as a result we also get decreased T4 as well. We can see subclinical forms of this as well, so just before really all of this starts happening, and we'll see an increased TSH and a normal T4. So for example, if we have an increased level of TSH, we'd expect to see increased T4 as well, and if the T4 is normal, this indicates some kind of subclinical abnormality here. And levothyroxine is the first line of treatment, and it's one of those drugs where we need to start with a low dose and gradually build it up. And of course, treatment aims are to maintain normal levels of TSH and T4, and as a result, therefore, we will have normal symptoms, so no signs of any of these what we just discussed. There are several different causes of hypothyroidism, as there are several causes of hyperthyroidism, and it's important to be aware of an emergency case here, so mixed edema coma. This is where we have severe hypothyroidism, causing severe hypothermia, altered mental state and bradycardia as well, and usually these patients will require intensive care support. Next we have hyperthyroidism, and this is exactly the same as thyrotoxicosis, i.e. we have too much of the thyroid hormones now, and again we can classify this into primary and secondary, with primary being a problem with the thyroid gland itself, and secondary being a problem from higher up the pituitary and the hypothalamus. And having an excess of this thyroid hormone essentially is less common than hypothyroidism, so it's less common to have more of it than it is less of it. But across the board, this condition and hypothyroidism as well is more common in women than it is in men. Graves' disease is the most common form of hyperthyroidism, and we'll talk a little bit more about this in a few moments' time. But in terms of clinical features, note how they're pretty much the opposite of hypothyroidism. So we're seeing an intolerance to heat this time. We're seeing palpitations, AF and anxiety, so a more of a tachycardic state than a bradycardic state as we saw before. We're seeing weight loss instead of weight gain, and one clinical sign we're looking at lid lag and goiter, which can be shown on examination. Once again, to point out, there are several different causes of hyperthyroidism, so from Graves' disease to a toxic multinodular goiter, an adenoma, something that's drug induced, so amiodarone's got quite a strong link here, or any drugs with iodine, for example. And then we've got investigations, so same kind of method: check your TSH, check your T4, check your thyroid antibodies as well, see if there's any autoimmune conditions going on here. And then for diagnosis, we can do exactly the same thing as we did last time and separate primary, secondary and subclinical aspects. A thyroid storm is the emergency form of hyperthyroidism, where we get a severe thyrotoxicosis and an exacerbation resulting in significant mortality. Just to hone in now then, Graves' disease we said is the most common cause of thyrotoxicosis, and essentially it's an autoimmune disease that affects the thyroid. So as we just said, one of the investigations we do are thyroid antibodies, and we'd see an increase in thyroid antibodies if Graves' disease was the cause. So as we see here, HLA-DR3, so human leukocytic antigen, is associated here as well, and antibodies act as receptor agonists. So the antibodies are stimulating the release of the thyroid hormones. In terms of treatment, we can turn to radioiodine therapy, a thyroidectomy, so a complete removal of the thyroid, but of course this would leave then lifelong hypothyroidism in contrast to the hyperthyroidism we're experiencing now. In terms of signs, We'll see pre-tibial myxedema. This is where we get thickening of the skin of the shins. We'll see eye bulging, so Graves' ophthalmopathy, a fine tremor as well. So we're thinking about the 4 P's of the hand when we think about examination. So the 4 P's being paper, palms, palmar erythema, and pulse. The exact cause of Graves' disease essentially is unclear. However, we believe it to be a combination of both genetic and environmental factors resulting in autoantibodies against the TSH receptor. In terms of the pathophysiology, the thyroid-stimulating immunoglobulins recognise and bind to that TSH receptor, and as a result release T4 and T3. So we're getting excess T4 and T3, and of course this is a primary problem going on here because it's a problem with the thyroid. In terms of goiter, so this is an enlargement of the thyroid gland, and this is actually often seen in Graves' disease as well. So goiter presents usually as a swelling in the neck. It may be bilateral or unilateral, and it's got a strong association with a thyroid that isn't functioning correctly. The causes behind this can be a variety of things. So it could be an endocrine cause like we've just discussed, so hypothyroidism, hyperthyroidism. Likewise, it could be a neoplasia, so benign or malignant. This is much less common, but still a possibility. We have inflammation as well, so thyroiditis. We have metabolic causes, such as iodine deficiency, but this is becoming much less common now. Drugs such as lithium can also induce a goiter. So in terms of signs and symptoms, this is really quite obvious. We're seeing a lump in the neck, but what's really clinically important about it is that it moves on swallowing. Patients may also report a change in breathing. They have difficulty breathing and swallowing as a result of the compression and the tightness in the neck. And they also will exhibit metabolic effects of hypo and hyperthyroidism if it's an endocrine cause. We can classify a goiter as well based on how cancerous essentially it is, and we can do this with ultrasound as well. Now, if the goiter is small, no treatment is necessary, but if it is slightly larger, we can use surgery as a thyroidectomy, or we can use radioactive iodine to treat this. And this brings us on to thyroid cancer, and although it's rare, it's still 2 to 3 times more likely in women than it is in men. And it's most common to develop in those in their 30s, and then we have a jump, so we have a bimodal distribution of appearance, and then those over 60 years old. There are different types of thyroid cancer as well, but these are the 5 that are really important to be aware of. So papillary carcinomas make up 80% of thyroid cancers and can occur at all ages. They're slow growing and have a slim chance of metastases. On the other hand, we have follicular carcinomas, which make up around 10% and are more common in the older age group, but 25% of these will develop distant metastases. We can have anaplastic, and this is the really bad one. It's very poor prognosis, usually 12 months or below, and we do tend to see this in elderly patients, which often go on to have palliative care. Next, we should consider a pheochromocytoma, which essentially is an excess of neuroepinephrine or epinephrine, but slightly to a lesser extent, as a result of a neuroendocrine tumour that arises from the chromaffin tissue. So this is normally within the medulla of the adrenal glands, but we can have extra adrenal chromaffin tissue as well that fail to disappear after birth. So the classic symptoms of this include episodic headaches, which have variable severity and duration, generalised sweating, tachycardia, and sustained and paroxysmal hypertension. In order to treat this condition, surgery is favourable as a laparoscopic adrenalectomy, but we must ensure blood pressure is adequate before we do this, so we use alpha-adrenergic receptor blockers before carrying out the surgery to ensure it's at a normal level. This condition does have association with other genetic conditions such as von Hippel-Lindau syndrome, as well as neurofibromatosis type 1 and multiple endocrine neoplasia as well. Lastly, for this video, we take a look at paragangliomas, which are a neuroendocrine neoplasm that can develop at various body sites from chromaffin cell tissue. It's hard to tell between malignant and benign forms, and therefore we recommend long-term follow-up. They can be sympathetic or parasympathetic in their origin, and most patients are asymptomatic with paragangliomas as long as the tumour isn't producing catecholamines. Of course, if the tumour does start to produce significant enough levels of catecholamines, it will cause symptoms, and these will be things such as episodic headaches, sweating, tachycardia, and hypertension, those that are similar to pheochromocytomas that we just explored. 75% of these conditions are sporadic, but 25% are hereditary, and therefore likely to present at an earlier age in the hereditary form. There are several different locations as to which they can arise, but the common sites of origin include those such as the carotid paraganglioma, and these can present as a painless neck lump with cranial nerve 10 or 12 palsy. That's everything for this video. Thank you for listening, and I hope you found it useful.